thank you very much for your patience, for your time, for still being there. We will now move to the last, third part of this evening, this morning, again, depending on where you're listening from. And time to bring on Dr. Moschen. Dr. Moschen is the head of the Christian Doppler Research Laboratory for Mucosal Immunology. He's also the assistant professor of medicine and senior scientist at the Medical University of Innsbruck in Austria. He has won several awards, amongst them the Sanofi Aventis Award, the Paracelsus Award, and also was awarded the Rising Star here of the, now I forgot the name, there I have it, of the United European Gastroenterology. Dr. Moschen, it's a pleasure and honor to have you again. We already had a lecture from you last year, and I leave the stage up to you. Thank you so much for being with us.
Thank you so much for the kind invitation. I'm really honored by this, by the chance to give this lecture today. So can you hear me?
I can, and I hope everybody else can as well.
That sounds good. So my topic today will be a little bit different. So I really enjoyed the speeches of my pre-speakers, of Ahmed Murat Hashim and Francisco Guarna. And my task today will be to talk about the gut-brain axis in irritable bowel syndrome and talking about mechanisms and therapeutic targets. And I decided to go more into a clinical practical way, as most of you will do clinical practice in your everyday living. I will briefly talk about epidemiology. I will talk to you on a clinical case basis how to correctly diagnose functional gastrointestinal diseases, particularly functional bowel diseases and IBS. I will briefly talk about pathophysiology of functional gastrointestinal diseases. We have heard a lot about important components like inflammation and the gut microbiota in this area, and then finally finalizing with an evidence-based treatment recommendation based on the most recent Canadian guidelines. And I hope that we will have interesting 30 minutes now. So I will just briefly talk about the epidemiology of disease, because epidemiology is usually quite boring. But if we think about gastrointestinal diseases, so we have to think about what is frequent and what is rare. And when we talk about functional gastrointestinal diseases, and this is a survey which was published this year in Gastroenterology from asking more than 73,000 adults all over the globe. And you can see that up to 46% of all persons asked report that they have some sort of functional gastrointestinal diseases. And when it comes to IBS, to functional bowel syndromes, well, it's up to 1 out of 4 patients who regularly suffer from IBS. So this is very frequent. So if we compare that to other gastrointestinal diseases like celiac disease, we're talking about perhaps 1%, or if we talk about IBD, we're talking about a prevalence of 0.3%. So we know a lot about very rare diseases, but we know less about very frequent diseases like functional gastrointestinal diseases. And this is very important because most of the patients that you will see in your clinical practice, well, they will have IBS, and we have to correctly differentiate these diseases from potentially harmful diseases. And so let's start with a clinical case example. So this is a typical case example out of my clinical practice. It's a young female born in 1995, very smart, studies sports and physics, and she's referred by her GP on spec celiac disease. So they asked me to rule out celiac disease. Her past medical history is quite unremarkable. However, she has been suffering from her symptoms for quite a long time. She's complaining about postprandial fatigue, distended abdomen, boborrhythmia, abdominal pain almost daily. Her bowel habits, she tends to constipation. Her bowel opens every 1 to 3 days, and she's already taken Bisacodil before. She says she has abdominal pain that improves after defecation. A clinical exam is quite unimpressive, with some abdominal distension and she's slightly pressure sensitive in the right lower quadrant. Asking the patient regarding her self-assessment, the patient is convinced that there is a nutritive trigger. She already tried a lot of different diets, like lactose-free diets and gluten-free diets. She brings a whole map full of tests, including IgG4 screens against nutrient allergies, and she also brings a microbiome analysis. And according to that, she says she has multiple sensibilities, including wheat, histamine, and so forth and so on, and her microbiome is a complete mess. So what are we going to do with this patient? So this is my first question, and it's not a poll, it's just thought that you think about this situation with me. So which diagnosis is plausible? Do you think she's celiac disease or a food allergy? Is she histamine intolerant? Does she have an inflammatory bowel disease or an irritable bowel syndrome, or does she have something like non-celiac wheat sensitivity? So let's go through that a little bit. So the first thing that we do, because the GP asked, is to rule out or to confirm celiac disease. What do we need? We need IgE antibodies against tissue transglutaminase, which we always have to interpret in coincidence with total IgA levels. So if you have an IgA deficiency, you can't use IgA antibodies to diagnose it. And these antibodies, they are clearly negative. However, there are other antibodies associated with celiac disease, which are positive. And this is a problem because the patient sees those. I was not asking for that antibodies. However, the patient says, but it could be because these antibodies are elevated. So what can we do to make sure that this patient doesn't have celiac disease? So we do additional testing for major histocompatibility complex, antigens like HLA-DQ2 and DQ2. We are lucky both are negative. Also the EMA antibodies are negative. So we can clearly root out celiac disease in this patient. This is very important. So you've heard about fecal calprotectin before from Ahmed, and this is also a very important marker that we use to differentiate between inflammatory intestinal diseases like Crohn's disease and between functional gastrointestinal diseases. And as Ahmed already pointed out very, very rightly, is that there is a gray zone in between those two diseases, inflammatory and non-inflammatory diseases. In between, it's difficult. However, fecal calprotectin is a very good negative predictor. So if it's really negative, you can really rule out an inflammatory condition in the bowel, and we're lucky in our patient, fecal calprotectin was negative. We were also talking about red flag symptoms. This is very important in our clinical practice. So we have to look for red flag symptoms. And what are those red flag symptoms? Well, it's unintended weight loss, of course, fecal blood anemia. We've heard about that before. It's nocturnal symptoms, monotonous crescendo symptoms, an onset of those symptoms at an age older than 50. More recently, we're going down to 45 years, fever, and a lot of comorbidities in the patient. So again, I want to ask you what symptoms of our patients now are really indicative for a functional gastrointestinal disease like irritable bowel disease? Is it postprandial fatigue? Is it more symptoms if the bowel frequency goes down? Is it improvement after defecation? Is it underweight or the nocturnal symptoms? So this is very important. And where are we going to look for those symptoms? So if you are interested in functional gastrointestinal diseases, you have to look for the Rome 4 criteria, which were published 4 years ago in the Gastroenterology, in Gastroenterology journal. So it's 224 pages of functional gastrointestinal diseases. It's the most boring edition I've ever read, I have to say. Anyway, if you try to categorize functional gastrointestinal diseases, you see there's a whole lot of different diagnoses that are situated within that framework of functional gastrointestinal diseases. And when we are talking today about functional bowel diseases, we are talking about this small section here. And this section includes irritable bowel syndrome, functional constipation and diarrhea, and distension and unspecified bowel disorder. So this sounds quite complex, but I think it isn't. I think you have to understand it, and I will try to explain it to you. So how do we categorize IBS in the conceptual framework of functional bowel disorders? So if we talk about IBS, the most important component determining IBS is always some sort of abdominal pain. And the second most important parameter is the presence or absence of constipation or diarrhea. And some patients will have both constipation and diarrhea, and then we call this mixed forms. So to diagnose IBS, we always have to have some sort of a pain and constipation, diarrhea, or a mixed form. If there is no pain and constipation, it's not IBS, it's functional constipation. And if there is no pain and diarrhea, it's functional diarrhea, as long as we rule out other reasons for constipation and diarrhea. And in between, there are other symptoms like bloating and distension, which are consequences of either diarrhea or constipation. And being that said, there are of course also diagnoses like functional bloating or distension. So keeping that graph in mind really helps you to correctly diagnose these different diagnoses within the framework of functional bowel diseases. So what are the diagnostic criteria, the Rome 4 criteria of irritable bowel syndrome then? So it's always recurrent abdominal pain, on average, at least 1 day per week during the last 3 months, associated with 2 or more of the following criteria, related to defecation, and associated with the change in stool frequency, and associated with a change in form or appearance of the stool. So this is very important, and it's a little bit complicated to keep those points in mind. I sometimes really have to look at it to make really sure. So going back to our patient, well, she is reporting about abdominal pain on a daily basis. Her symptoms are present for longer than 1 year. If her stool frequency goes down, this is associated with more pain, and there is an improvement after defecation, and she tells us about 3 to 4 bowel movements per week. So overall, I think there is pain and there is constipation. So in this patient, we have ruled out celiac disease, and we have a negative fecal calprotectin. It's a young patient. I think we can clearly give her the diagnosis of an IBS with constipation. And I think this is how you should in your clinical practice also go for a correct diagnosis. And now looking at the recent guidelines of the Canadian Association of Gastroenterology, I was quite astonished because the Canadians were quite restrictive. And what they said, well, if you have a patient with symptoms like that, you should rule out celiac disease. And if you have a patient who is older than 50 years, you should send him for a screening colonoscopy to rule out another reason for his or her symptoms. However, they are against everything else, against CRP, against fecal calprotectin, against routine colonoscopy, and so forth and so on. I think in my clinical practice, well, I also like to be restrictive with diagnostic measures. However, it's not always possible to go for these very strict guidelines. Another very important aspect with our patient is that she reports that she has problems associated with food intake, and she thinks that she has a food allergy or food intolerance. So I have a question, one more question for you. So from these 2 patients, who do you think is more likely to have a food allergy? It's of course a joke question because it's quite clear, but why do so many patients think that they have a food allergy when indeed they have IBS? And this is a very important question. So food triggers clinical symptoms in the majority, in 2/3 of IBS patients. And the mechanisms behind that, they are poorly understood. So looking for adverse reactions to food, well, this is a quite complicated topic because we differentiate between toxic and non-toxic reactions. And the non-toxic reactions, we again subdivide them into immune-mediated reactions like allergy, usually an IgA-mediated allergy, or non-immune mediated like enzymatic or pharmacological. And what you can see here is the majority are non-immune mediated. And in the next part of my talk, I would like to talk talk to you a little bit about the mechanisms associated with food intolerances in IBS, because there has been tremendous progress in our understanding in the last 2 to 5 years. And I just want to share with you a couple of those aspects. And this is a very famous study published in Gastroenterology by Annette Fischer-Rabens already 6 years ago or so. What she did is she took patients, 36 IBS-D patients with adverse reactions to food and 10 healthy controls. And then she performed a very fancy method called confocal laser endomicroscopy. So using a microscope, which is put on the top of a colonoscope, she can go into the colon and or into the duodenum and directly look at epithelial cells and look if the gut gets more leaky or not, if the gut mucosa is exposed to certain food triggers. And at food triggers, she took just 4 different typical triggers like milk, like wheat, like yeast and soy. So what they did, they put the colonoscope in, then they injected 10% fluorescein. That's a substance that has a fluorescence when you put ultraviolet light on it, what you use for this confocal laser endomicroscopy. And then they sprayed milk on it, wheat, yeast and soy extract. And then they waited for 5 minutes if they see any reaction here. And if not, they washed it away and took the next one. And interestingly enough, they found the reaction, a leaky gut reaction, in 22 out of 36 patients tested in the IBS group, and no positive result in the control group. And even more interestingly enough, they found if they made an exclusion diet based on their test, those patients fared much better than the other ones over the next year from their clinical problems. So this was really a very interesting study. But the question is, so what is the mechanism that provokes a leaky gut reaction with the release of fluorescin into the lumen within only 5 minutes? Is it really an allergy? And here there have been published a couple of very good papers recently. And what they showed is that the intestinal epithelial cells, so the cells that are lining the surface of our gut, they include very specialized so-called enterochromaffin cells. And within enterochromaffin cells, these cells are again very specialized because these cells, they produce high amounts of neurotransmitter and they are directly interacted with the nervous system. And in a more recent study, it was showed that these cells, which we now call neuropods, are interconnected with the brain with only one interconnection. And this framework goes from one in the other direction. And also, most importantly, the substances that trigger such a reaction are typically food components and secondly, bacterial metabolites. And this brings us back to Professor Juana's talk that the microbes and particularly the things that they produce, their metabolites, are very important in regulating gastrointestinal physiology on the one hand, but also functional gastrointestinal diseases. So what is the role of the microbiota in functional gastrointestinal diseases, specifically in IBS? So there is a load of studies regarding this topic, but I just want to show you one particular study which I think is very helpful and which really helped me to understand the topic from a certain point of view. This was a colleague from Canada again, who did a very interesting study. He and his team, they took IBS-D patients and control patient, and they collected the stool of those patients, and they transplanted the patient's stool into germ-free mice, making so-called gnotobiotic mice. And then they looked at those mice and see if those mice received the stool from IBS-D patient would develop IBS, and those from control patients would not do so. And what were the results? And this was quite interesting. So looking at the composition at the structural composition of the microbiota between healthy controls and IBS mice, they did not find any difference. However, looking at serum metabolites in those mice, they found a clear discrimination between IBS mice and healthy mice on this principal component plot. And what were the consequences? Despite having structurally the same microbiota, those mice that have received the stool from IBS patient, they developed a reduced intestinal transit time. They developed diarrhea. They developed a leaky gut. They developed more inflammation, and they developed psychological alterations like more anxiety in light preference and step down tests. So very importantly, it's obviously not so important what bugs are there in IBS, because it's pretty much the same than in healthy control. The question is, what metabolites do they produce? And we have maybe to interfere with those metabolites for future therapies. So this brings me back to the way how we should treat, according to the current guidelines, IBS in our patients today. And I will underfit this data a little bit with a couple of studies. And well, this mostly reflects the way we do it here in Middle Europe. I think IBS, well, it's not rock solid science all the time. So different aspects in treatment of IBS will be done a little bit different in different parts of the world, and I'm well aware of that. So looking at the Canadian guidelines as well. So if you have a patient, you have ruled out celiac disease, and as in our case, you have a negative fecal calprotectin test, what should we offer our patients? Well, we should offer our patients soluble fibers. We should offer them peppermint oil and antispasmodics at the first glance. This is very important. And why is this? So there is quite good data that some fibers are beneficial in the treatment of IBS, but not all. As you see here in this large meta-analysis, certain fibers like bran are not very helpful, while others like ispaghula husks, they are indeed helpful. And these ispaghula husks are the most widely used fiber for the treatment of IBS. So we also here in Europe have quite good experience with another fiber like BHGG that we use in our patients. The other thing is the role of peppermint oil. The sense of peppermint oil is to reduce the pain sensitivity of these enteral nerves, and there is quite good data regarding peppermint oil extracts in this meta-analysis studied in many different studies over 2 decades. So going for a baseline therapy, what is the right therapy for IBS now, with a strong focus on the patient that I introduced into you? Well, this patient is of course not a good candidate for a low FODMAP diet, because low FODMAP diet is something that we use in IBS-D. However, we should offer our patients psyllium or another fiber which has shown efficacy. We should offer them peppermint oil, and also there is of course a role for probiotics to improve IBS symptoms. However, we have to be a little bit careful what sort of probiotics we use in IBS with diarrhea and in IBS with constipation. So this, to summarize this first part. Now we have to go back to our patient. So we have a patient now who clearly has IBS with constipation. Personally, I like to use salts as laxative. I use a lot magnesium salts like magnesium citrate, which helps to keep the water within the gut lumen as an osmotic laxative, and it helps to relax the smooth muscles a little bit. However, there are different other methods like linaclotide, like SSRIs, like lubiprostone, and like certain treatment options like behavioral therapies or hypnotherapy, and I will talk about that in a minute. So first, talking structured about laxatives, what options do we have? So we usually start with the fiber, maybe in combination with the salt. My personal opinion, it's better to use capsules than to use soluble salt, because after a couple of days, patients don't like to drink them anymore. We can use sugars or Macrogol, and these are binding waters. Then we use other laxatives like bisacodyl, natrium picosulfate, or anthracinones, which induce motility, thereby reducing absorption, and this increases the stool volume. However, if we can't manage the constipation with these two columns, there are newer options that we can use for IBS with constipation, like linaclotide and lubiprostone, and both of them, they induce the secretion of chloride, and thereby again provoking an efflux of water and increasing the stool volume, which helps the patient with the defecation. We've seen that really nice this really nice clip before my talk, and that's why you are well informed about the options of Eucarbon in these patients as well, because it contains three very interesting strategies, namely charcoal. Charcoal was not in my list, but as I've shown you before, it absorbs certain substances, metabolites from the bacteria, thereby preventing and reducing interaction with the gut-brain axis. So I think this absolutely makes sense. This senna leaves and rhubarb roots, they fall into these anthraquinolone lines in higher doses. They serve as mild laxatives, and essential mint oils and essential fennel oils, they have a carminative and spasmolytic effect. So this is exactly what we would use in mild constipation in our patient. And I think in this aspects, Eucarbon really makes sense and contains components that are according to current guidelines. So what about those newer substances like linaclotide? What is linaclotide? Linaclotide, from a pathophysiological standpoint, is like guanylin or uroguanylin, an activator of guanylate cyclase C, which activates a G protein coupled protein, which activates this protein kinase, which again activates the cystic fibrosis transmembrane receptor, which is important for chloride secretion. Linaclotide we use once a day in 290 milligrams for moderate to severe IBS in adult patients. And this is the very famous New England Journal study, which showed that it reduces abdominal pain and it increases the complete spontaneous bowel movements per week, which is the FDA endpoint for new substances for the treatment of IBS C. The other substance is lubiprostone or amititia. It's less well known. It's quite old. It's not approved in Austria, but we can receive it from Switzerland, and I have to use it for some patients. I have used it for some patients with quite some good success. The first study was published already in 2007 in Gastroenterology, which led to its approval in the US and in Switzerland. And this is the 1 year data. And as you can see, up to 45% of the patient benefit from such a treatment over 1 year. The dosing is 2 times a day, 8 to 24 micrograms. And from a pathophysiological perspective, it's a bicyclic fatty acid derived from prostaglandin E1 and also activates a chloride channel. So this is also a very helpful treatment. So what is the role for tricyclic antidepressants and for selective serotonin reuptake inhibitors? Here we have to keep one thing in mind. If you have a patient with diarrhea, the right choice is probably the use of amitriptyline or Sarotin in a dosage of 10 to 25 at a maximum 50 milligrams per day. If you have a patient with IBS-C, it's more wise to use an SSRI like citalopram, fluoxetine, or paroxetine in these patients, and the and the efficacy of such therapies in IBS D and C was demonstrated in various studies over almost 3 decades of scientific efforts in IBD. Here in Europe, and particularly in Austria, we also like the opportunity of behavioral therapies and particularly hypnotherapy. So this is a typical therapy that helps to intervene with the gut-brain axis from a central perspective, so inhibitory neurons suppressing pain and these disturbances in the gut. And there is a huge body of data regarding both treatment options. The problem is, do you really have doctors and healthcare professionals who can provide that service on a state-of-the-art basis? And this is a big problem in many countries. So coming back to the guidelines, well, psychological therapies from the Canadian guidelines are clearly recommended, both cognitive behavioral therapy and hypnotherapy. Regarding pharmacological therapy, well, we can use SSRIs or amitriptyline, as I've told you before. And regarding constipation predominant IBD, lubiprostone or linaclotide are 2 treatment options in very severe cases. So I think I'm in time, and this brings me to the end of my talk. So starting with a clinical case example, we've learned today about a proper and correct diagnosis of irritable bowel syndrome, and to differentiate that from other functional constipation and functional diarrhea. I think this is very important. I've shown you a couple of new aspects, how food triggers symptoms in IBS, and I'm quite confident that we will see newer therapies intervening with those pathways in the next year. So this is very exciting. The microbiome, gut, brain axis, and of course the nutrient axis. And finally, we've talked about the state-of-the-art treatment, particularly of IBS-C. And I hope this was helpful for you. I thank you very much for your attention and wish you a very nice evening. Thank you very much indeed.
Thank you so much, Dr. Moschen. Wonderful talk, and definitely have learned a lot again from your presentation. So maybe we move on to some Q&A here. Can you hear me properly?
I can hear you very well. Thank you very much.
Okay, there were some complaints earlier. I hope this is now all solved here. I think some of the questions you already answered throughout the role of SSRI, and also which combination of drugs to use. Here I have one. When are you definitely going for an endoscopy to evaluate a patient with putative IBS-C?
So I think this is a very important question, because as being said, I think IBS is the most frequent diagnosis, and the biggest danger that we have is, well, to put it on light shoulders. So if you have a patient who has new onset symptoms, crescendo symptoms, and has an older age and has constipation, I would always go for a colonoscopy. You don't want to oversee a colorectal cancer or something like that. And you know, the recent American guidelines, they suggest a screening colonoscopy from an age of 45. And in patients with new onset symptoms, I'm also quite well, the decision is quite easy to put a patient with 40 years with new onset symptoms for a colonoscopy. I think you should not oversee colorectal cancer. This is very important.
Okay. In your clinical practice, do you use any further diagnostics in specific clinical situations?
So being that said, I have to say, we are talking about, I brought a clinical case example of a very simple case of an IBS with constipation. However, in my clinical practice, I often see patients with very complicated forms of constipation, not only IBS. And in these cases, we have to differentiate if there is something like a outlet obstruction. We call that dysynergic defecation, or if it's a slow colon transit time, because this makes differences in the therapy that we put for our patient and for the licensed drugs that we use for that. Well, I use sometimes radio park markers, and we sometimes use techniques like MRI defecography, where we can monitor the defecation act in our patient. But I think this is a very special situation, and we do that in a multidisciplinary team.
Okay. Is it safe to use sulfur for G6PD cases, in your opinion?
I'm not seeing so many patients with glucose 6-phosphate dehydrogenase deficiency, but sulfur is elemental sulfur, and from a chemical perspective, I do not see any problems to use sulfur in the concentration that is in Eucarbon for those patients as well. I would be quite reluctant to, so I would use it.
Okay. When you mentioned the Eucarbon again, Eucarbon and in combination with anticholinergic drugs, would that be a good combination to cover the Rome criteria?
So overall, I think it's a good option to do so. So usually we go. What I usually do, I go for one strategy, and if this strategy is not good enough, which is often the case, I have to go for a second one. And I think the advantage of Eucarbon is that it combines a couple of different mechanisms in the same treatment option. And if Eucarbon is not effective enough, well, I think you have to combine it with the second option. I think this absolutely makes sense, and I would do that.
Okay. Do you have any preference which probiotics to use for certain patients?
So this is a very interesting question. So there is good data regarding probiotics for IBS, but always the question is, what is the right probiotic for what patient? Well, I think there is no good evidence on that. However, if the patient is suffering from diarrhea, from higher volume diarrhea, and has more like distension and has more like flatulence, I usually go for bifidobacteria. And if the patient has colonic symptoms like constipation, I prefer to go for lactobacillus. A lot of colleagues here in Europe would go in this direction, but this is not rock solid evidence. This is, well, clinical experience, I would call it.
Okay. If the patient is over 70 years old with chronic constipation and unremarkable enterocolonography, do we need a colonoscopy?
Where I work, we usually don't do a CT colonography except there is a contraindication for a colonoscopy. I do not see reasons why not to go for a colonoscopy in a 70-year-old patient. We usually do that. However, if the patient is indeed in a very bad shape and you don't want to go for a colonoscopy, or the capacity are not good enough, CT colonoscopy can be an alternative. You can miss smaller polyps. If you have a very experienced radiologist, you should not miss bigger lesions.
Okay. Well, Dr. Moschen, I think we're good here with this, and we're also getting the signal of time. I thank you very, very much. It was a great pleasure. And then I look forward to hopefully seeing you again soon and hearing you on another lecture as part of the International Gastroenterology Educational Series.
It was a great pleasure indeed. Thank you so much for the kind invitation.
Yeah.